Hi, so today we are going to discuss about diabetic ulcer. So basically, diabetic ulcers are one of the most common cases that will be seen in surgical wards. So for both the undergraduates and postgraduates, one of the most common case that is being kept in short case examination. So every day you will see a diabetic ulcer in your ward, and you will be grading the patient. Will keep improving the wound, and finally you will send the patient with uh, split skin grafting or a flap or something else. So we'll discuss about some of the common cases, common case scenarios that were seen in our hospital surgery or in the last month. So before going to the cases, so we'll discuss how to proceed with the workup of a diabetic foot patient. So when initially patient presents, they will present with a small ulcer or with a pus discharge or with a small or very massive ulcers. The patient will have symptoms like fever, difficulty in walking. If the patient is in sepsis, the patient will have high grade fever, decreased urine output. So there are a lot of symptoms and signs will be going on with the patient. So once this patient will admit the patient, will immediately prepare the patient for wound debridement. So this first initial wound debridement, the first sitting of wound debridement is very, very important. And the first debridement will always be the best wound debridement. So you have to eliminate all the source of infection when you take the patient for first emergency debridement. We will do WBC counts. We will see whether the counts have been increased. We will do wound swab and culture to look after what organism is causing the infection, and we will start antibiotics. Initially, we will start empirical antibiotics, and then once the wound culture and report comes, we will change the antibiotics according to the sensitivity, and we will monitor the patient whether he is improving after changing the antibiotics. We will monitor the input output of the patient. You will monitor whether the surrounding swelling is being reduced. You will do limb elevation for the patient. So these are the initial workups. If you are suspecting some arterial disease or venous disease along with it, you will go for duplex imaging. If the patient is having a gangrenous foot or unsalvageable foot or unsalvageable toes or digits, we have to amputate the toes or the gangrenous part to eliminate the foci of this infection. So if you keep a foci of infection there, your wound is not going to improve. So whenever you do debridement, you should eliminate all the source of infection. So we'll go into the case scenarios. So this is the first case, 62-year-old gentleman from Puducherry. So basically he came with complaint of swelling over the left foot. So he had a rat bite a week earlier, like 10 days back. He had a rat bite 10 days back and over the left foot. So he developed a small ulcer over the left foot. So eventually, like he ended up with pus discharge and frequent episodes of fever. So he went to some hospital. Initial debridement was done there. Still his symptoms were not improving. So he presented to us, and he is a known case of diabetic mellitus for the past 6 months, and he is on irregular medication. So on examining the patient, so he had a debridement in the other hospital. So when he presented to us, he didn't present with swelling. He presented with a debrided ulcer, and it's 20 cross 15 cross 3 centimeter ulcer present over the dorsomedial aspect of the left foot, extending from the lower one third of the left leg to the distal foot up to the metatarsophalangeal joint. We'll be seeing the image in a while. So size we have seen, and it was irregular in shape. The floor was covered with slough. The margin was not well defined. There were purulent discharge present. On palpation, warmth and tenderness were there. Surrounding induration was present. And the main thing is inguinal lymph nodes were present on the left side. So whenever you have some ulcer over the foot or any infection over the foot or leg, you should look for inguinal lymph nodes, the drainage region. The most of the patient will have inguinal lymph nodes. If inguinal lymph nodes are present, definitely there's going to be infection in the leg or foot. So I said the patient was diagnosed with the diabetic and he is irregular on medication. So he had diminished sensation over both the foots, both feet. And the main thing is we have to always palpate the pulses, starting from the femoral pulse, popliteal pulse, anterior tibial artery, posterior tibial artery, and we end up with dorsalis pedis artery. So most of these patients will also have absent or feeble pulses. Mostly they won't have, they will be having only feeble pulses. If there is any associated arterial diseases going on, the patient will have absent pulse. And in case of arterial disease, you will have the patient will present with dry gangrene. And if it's superimposed with infection, he will present with wet gangrene. So in this patient, the patient had feeble pulses. So next, we took a X-ray of the foot. There is no obvious bony injury noted in the foot. So his fasting blood sugars were 194 milligram per deciliter. His postprandial blood sugars were 269. He was uncontrolled. We started him on insulin, that is Actrapid and Mixtard. So we monitored his sugars continuously, but then it was not coming up to the normal value. Hemoglobin was 14.2 grams per deciliter and the WBCs were raised 20,140. Platelets were normal. And the main thing is this patient from admission, the patient's RFT was initially it was mildly elevated, and upon continuously we were continuously monitoring this renal parameters, and it was deranged. We took wound culture and sensitivity during the first wound debridement, and it was Staphylococcus aureus, and it was started on appropriate antibiotics. We did a Doppler study also to look for any arterial or venous pathology. So he had some minimal atherosclerotic changes over the peripheral pulses. So this is the post-operative wound of this patient. So the floor is completely covered with slough, and the patient is draining with pus. Like the pus, there was pus discharge from the this region, tracking down in the lower one third of the leg, and initially he had erythematous changing surrounding induration were all present. So this is after some 3 to 4 sittings of wound debridement. He was having this sort of pus discharge and slough. So the wound was not at all improving. His RFT was deranged and his LFT started deranging. Urine output is coming down. The patient had frequent episodes of fever. So these all denotes the patient is going towards multiple organ dysfunction syndrome. So in order to save the life of the patient, we planned for below-knee amputation of the left leg. So that is the only thing we can do now. So if the patient has presented a bit earlier, and if he had responded to the sensitive antibiotics, and if he had not gone towards MODS, the wound would have improved and we would have got nice granulation tissue. So here, very, very less granulation tissue is present in the wound. Apart from that, the wound is completely covered with slough and pus. So only a very less region of granulation tissue. So if this patient has had a nice granulation tissue and the wound is being improved, we would have sent him with split skin grafting, but that was not the case here. We ended up with, we advised him with below-knee amputation in order to save his life. Okay. So the case 2. So this is the second case. So this guy is, this man is a 71-year-old male from Puducherry. He is a known diabetic for 20 years and he is on regular medication. So he came with complaints of ulcer and foul smelling, purulent yellowish discharge over the left foot for 1 week. He also had frequent episodes of intermittent episodes of fever. For 1 week, he had taken some antipyretics, but then he had frequent episodes of fever. So on taking history, there was allergy history of a foreign body injury, non-prick injury, 15 days back, and he sustained injury to the left foot. So he had not noticed the prick since he had the most common complication, or the most common complication of diabetic patients is diabetic neuropathy. So this is not a surprise. This patient did not have any sensation over his injury. So he missed that injury. So eventually he developed ulcer over the third toe. So when he developed ulcer over the third toe, he went to a hospital. By the time it was a state of wet gangrene, it seems. So third toe ray amputation was done in outside hospital. Following which he presented to us with progressive ulcer, foul smelling discharge, and swelling over the left foot from the even the smell discharge from the amputated side. And the main thing is he had blackish discoloration over the fourth toe also. So on local examination, this patient below the like in the plantar aspect, just beneath the amputated third toe and the infected fourth toe, he had a 7 cross 7 centimeter swelling with multiple pus points discharging pus. It was irregular in shape, fluctuant, warmth was present, tenderness was present. From the amputated third toe and the interdigital area between the third and the fourth toe, there was massive pus discharge present, and the fourth toe was soddened. It was blackish, discoloration was present, and we could see a impending wet gangrene over the fourth toe. So obviously, this man also had inguinal lymph nodes over his leg, left inguinal region. Peripheral pulses were feeble, and obviously the sensation was diminished over the foot. So we woke up the patient. Hemoglobin was a bit low for into a male individual. It's 9.2 milligram per deciliter. So WBC counts were 19,470. Neutrophils were 90% actually. It was raised. His random blood sugars was 305 milligram per deciliter. He was not at all in control. HbA1c was 8.9. Shows he is chronic under not controlled in his diabetic status. His urea and creatinine was elevated on admission. The urea is 62 and creatinine is 1.9. And we did the urine protein examination, and there was sugars present over the sugars 2 plus in urine sample. So we did wound culture and sensitivity. Pseudomonas aeruginosa was the organism. So it was sensitive to piptas, tetracycline, linezolid, imipenem, and meropenem. We started with half dose of piptas because his renal function was a bit deranged. So we took the expert opinion. So it was started on half dose of piptas because piptas is a broad spectrum antibiotic eliminated through the renal system. So we cannot give high dose of piptas. And along with that, we gave oral linezolid also. So this is his X-ray. This was taken in our hospital. This is the post reamputation of the third toe, and this is the fourth toe. So the treatment is we did. So initially, on the first sitting, we did fourth toe reamputation. Since it went for wet gangrene, we could not save the fourth toe. We did wound debridement and multiple 2 to 3 settings of wound debridement was being done for this patient. And our follow-up investigation on post-operative week 4, it's like hemoglobin was a bit dropped, 7.9 gram per deciliter. So we started him, we transfused him with 2 units of packed red cells. His WBC was not coming down even with sensitive antibiotics. Neutrophils was elevated 79%. Even with insulin, his sugars were poorly controlled. So obviously, for this patient also, he's going with deranged renal parameters, decreased urine output. He also had breathlessness episode in between, which suggests acute respiratory distress syndrome. So all these denotes he's moving towards multiple organ dysfunction syndrome. So in order to save the patient's life, we plan for below-knee amputation. So this is the wound. So you can see only a very less granulation tissue present, and the other region in the plantar aspect of the foot is completely covered with slough, necrotic slough, and first discharge. So third toe is amputated, and this is the fourth toe amputation done in our hospital. So since his wound is not getting better, he was advised for below-knee amputation. So this is the third case. So this patient's age is 62. He is a resident of Puducherry. He is a known diabetic for almost 4 years on treatment. So he presented with complaints of ulcer in the right leg for 1 week associated with first discharge, and he also had pain and fever for the past 3 days. And this guy also had a allowed history of trauma 1 week before over the right leg. He sustained injury near the ankle joint when the patient had swelling first discharge, and which was foul smelling first discharge. So the patient is diabetic. He is irregular on his medication. So this is the wound picture. So he had a 3 cross 5 cross 3 centimeter ulcer over the medial aspect of the ankle joint, just above the medial malleolus. There was pus draining through the ulcer. Surrounding induration was present, and erythematous changes was present. The patient had mild to moderate cellulitis over the lower aspect of the leg. Tenderness was present in the lower aspect of the leg. He also had a diminished sensation of his foot, and obviously inguinal nodes were present. And for him, the pulses were normal, and it was normally palpable. So his hemoglobin initially it was around 7 gram per deciliter, but we transfused him with 2 ERBC. So after 2 units packed red cell transfusion, his hemoglobin came up to 10.1 gram per deciliter. His counts were also elevated, 16,570 cubic millimeter. The neutrophils were elevated 94.2%. His RBS was not controlled. Again, RBC was deranged. His Doppler study showed atherosclerotic changes in the peripheral vessels, but then his pulses were okay, normally palpable. On clinical examination, the atherosclerotic changes were very minimal, and he had a triphasic flow in the Doppler and no obvious venous pathology noted. So this is X-ray. So there is some sort of bone erosion present over the calcaneum, and since he went for ARDS and moving towards multiple organ dysfunction syndrome, he had first discharge from the ulcer that was tracking down from the lower one third of the leg. It was like piercing through the fascia, involving the muscles. We planned for below-knee amputation. This is the post-op picture of the below-knee amputation. So we have done Burgess procedure here. We monitored him closely for any seroma or failure of the flap, but then he did well with elimination of the infective foci and appropriate antibiotics. He didn't have any necrosis over the suture line, and the flap was taken nicely. We discharged him, and we're planning to keep him on prosthesis. So this is the fourth case. This is 70-year-old female from Puducherry. So this lady has complaints of ulcer over the right great toe for 1 year. So it's a long time. So this is ulcer, complaints of ulcer over the right great toe for 1 year, and she had a serious discharge for the past 1 month. And the main thing she presented over now is she had swelling and pain over her right leg. She's a known case of diabetic and systemic hypertension on regular treatment. So she had a 1 cross 1 centimeter ulcer present over the plantar aspect of right great toe. So this is the wound actually. So this is a type of pressure ulcer, trophic ulcer, and you can see the punched out ulcer. So the edge of the ulcer is punched out. So depending upon the edges, we classify the ulcer. Like if it's punched out, it's trophic ulcer. If the edge is sloping, it's healing ulcer, it's venous ulcer. If the edges are undermined, it's TB ulcer. If the edges are rolled fully white, it is basal cell carcinoma, rodent ulcer. If it's raised and averted, it's squamous cell carcinoma. So she also had some mild pus discharge from this wound. And the main thing she presented, she had pain and swelling over the lower one third of the leg. So she presented with moderate cellulitis. The warmth and tenderness present, surrounding skin was sawed and punched out edge, and the margins are well defined. So if the ulcer is not in the healing phase, there will be ill-defined margin, and the floor is nicely covered with granulation tissue, and the ulcer rests over the uh, muscles and bones, and minimal pus discharge was present. Generally, swelling present over the right leg up to mid one third of the right leg, warmth and tenderness present. Her peripheral pulses were normally present, and she had diminished sensation over her right foot. This again suggests diabetic neuropathy, which is a complication of long-standing diabetic mellitus. So, but then she presented at the right time, and she had some pain, and she had swelling. She presented to us with moderate cellulitis. So, her hemoglobin is 10.2. Counts were mildly elevated, around 15,000. Neutrophils were elevated. Her urea and creat were normal. RBS is 250, but then we changed her doses with physician opinion, and then it came under control. Her electrolytes were normal, and the sugars were nil in urine routine examination. There were no traces of albumin. We took culture and sensitivity. It came with the Klebsiella pneumoniae sensitive to imipenem and meropenem. She was started on sensitive antibiotics, and we gave her limb elevation. We gave her IV antibiotics. We controlled her diabetic status. So then, with all these measures, her cellulitis subsided. This is her X-ray. It is normal. So this is trophic neuropathic ulcer, and we did regular dressing and cleaning with appropriate antibiotic covering. So in diabetic ulcer, the main thing is we have to eliminate all the focus, and this dressing is one of the most important aspect when it comes to diabetic ulcer. So you have to daily open the dressing. So in case of some bad wounds, you have to open the dressing twice daily. You have to do daily dressing. Or else if the wound is okay, if the wound is getting better, if the patient is getting better, very minimal amount of slough and very minimal pus discharge, you can open it once in every 24 hours. So we have to do this dressing in a very sterile manner with sterile gauze, pad, sterile instruments, everything. So we have to initially open the wound. If slough for any pus discharge person, we have to eliminate all. We have to evacuate all the pus discharge. We have to eliminate all the slough. We have to do minimal bedside dressing. We're removing all the infected foci over there. We'll have to do a wash, povidone iodine, hydrogen peroxide, saline wash. Everything has to be given. We can soak the wound in usual solution for some 20 to 25 minutes before starting the dressing. There are so many topical applications are there, like debridates, autolyse to lyse the slough, and all the sloughs will be eliminated from the wound. And there are topical applications like the placenta gel to improve the granulation tissue formation. So if the wound is getting better, if there is adequate blood supply, if there is adequate oxygenation to the wound, if you are doing sterile dressing, all these sloughs and pus will get settled down, and the wound will start getting better with nice granulation tissue, nice pink bleeding granulation tissue. So the final outcome we are expecting in a diabetic wound, for a healing wound, is we have to bring that diabetic wound with granulation tissue. So we have to do in a sterile manner. So there is a Bisagard regimen being followed for diabetic ulcer. We have to elevate the leg or to reduce the edema. In case of dressing, 4-layer bandage dressing is being followed, being advised. Like initially, orthopedic wool, then cotton cream, then cohesive bandage, and then elastic bandage. So this 4-layer bandaging is also being followed. So if if the wound depth is very more to continuously, if you want to remove the slough and to improve the granulation tissue, there are a lot of recent advances being followed now. So one such advance is back dressing, back assisted dressing. So You will initially clean the wound. You will make the wound in a sterile manner. We will keep a foam and some layer of gauze, bacteria, everything. We will connect it to the suction system. A negative pressure of around 125 mmHg is being maintained. So we will uh, close the wound with this suction tube that is kept in the floor of the ulcer and connected to the suction system. So it will continuously remove the slough or the necrotic material over the floor by suction, and it will improve the microcirculation, and it will also improve the granulation tissue. So once the back is done, you need not open the wound every day. You can inspect the wound once in 3 days, or if the wound is okay, if the counts are coming down, if there is no fever or surrounding edema, you know soakage over the dressing, you can open the wound in 5 days also. So this can be done in a single setting. If the wound is not improving, you can do it multiple settings. So once this granulation tissue comes, what we'll do? So once this granulation tissue comes, we have to cover the wound. So we will cover the wound with either split skin grafting or flap cover. So mostly in general surgery aspect, we will do if it's flap, it will be done by the plastic surgeon. So in our OT, general surgeons will do split skin grafting. So we will take skin that is epidermis and a part of dermis split skin using Amrish knife and Downey's blade from the type most common donor area is type. Take appropriate length and size of the skin, and we will mesh the donor skin. So this meshing is basically done to improve the uh, improve the surface area, and to when you keep the meshed skin over the recipient area, any seroma being collected will be coming out through the mesh, and it won't get collected underneath the uh, recipient area, and it won't infect the donor skin. And also for plasma invasion to get new nutrition, this machine will help. And there are 3 stages for this uptake: stage of plasma inhibition, stage of revascularization, new vascular pedicles will grow, new vascularization will be there, and stage of enosculation. The anastomosis will be in the newly generated vessels, and the old one will happen to nourish the split skin graft that has been placed over the diabetic foot. Uh, so this is the final outcome, and there are some uh, medications are being given. So on such drug is pentoxifylline. So it will reduce the viscosity of the blood, and it will improve the microcirculation of the wound. Apart from the anti-lipidemic drug like statins are being started to decrease the cholesterol levels. If the patient is having any arterial diseases, we'll start anti-platelet drug with aspirin. Low-dose aspirin is being started. So these are all the drugs. So the main thing is education of the patient. So once you admit a patient, you worked up the patient, you have done all the measures to bring the patient to the normal pre, just like a normal status. You have to educate the patient. You have to tell them how to keep their wounds clean, how to keep their legs clean. Because the basic thing is this patient will have, due to diabetic neuropathy, they won't have this pain sensation. So if they get any very small injuries to their foot or their leg, they won't notice it. So eventually it forms ulcer, and all this sequelae is being happening to this patient. So oil discharge, we should educate the patient. Whenever they go, they have to wear chappals, microcellular chappals, MCR chappals will be good. So patients be advised to wear chappals whenever they go. So while entering home, while coming, they have to always wash their uh, legs. So while washing, they have to inspect their legs mainly over the interdigital clefts. In between the toes, they have to examine in between the toes whether they have got any injury, whether they have any thorn prick or needle prick or some small stones may cause injury. So they should not miss this injury in between the toes. So they have to be educated to look in those areas. They have to regularly wash their legs. So they have to keep their monitoring. They have to keep their diabetic status under control. They have to monitor sugars every month, and if it's increased, they have to adjust the dose according to the values. Uh, so these are all the measures. These are taken towards a diabetic patient. So the cases we saw here is all extreme cases where uh, all the measures were failed and patient presented after a certain extent where his limbs could not be saved. So whenever these patients have, you have to advise them if you have any small ulcer or small swelling or small cause discharge, especially in a diabetic patients, they have to show it to a surgeon and it has to be inspected, palpated, and eliminate the source of infection. Uh, so these are all the basic things you have to know about diabetic food ulcers.